So I was in North Carolina on visiting my relatives, and when Professor Torres said, I need 5 questions, so I threw 5 questions together, I think sitting at the breakfast table. I didn't put a lot of thought into them, I just rattled off 5 questions real quick. So in looking at the questions, they're probably not very good. The one about the burn thing, I would use lower extremity if I wanted you to deal with the whole extremity. Posterior half, anterior half would be the whole. When I used the word leg, I wasn't even thinking that the leg is really defined as from the knee to the ankle. So the other question, so if I make a mistake on a question, I'll either give you credit for the question or throw it out, one of the two. Keep in mind that if I throw out a question and you happen to have guessed it right, even though there was no right answer, you're penalized. The other point is on the stabbing thing. I was shooting for the rhomboids, but I completely, brain farted that the iliocostalis, probably not iliocostalis, but the spinalis certainly goes up that high. So, or at least a part of it. But the number of centimeters away from the spine, you wouldn't hit spinalis. That means, I can't remember how many centimeters.
3 millimeters.
Centimeters.
Oh, centimeters.
Centimeters, yeah. Centimeter is, that would be over an inch, and the spinalis is just barely a centimeter. So
You'd hit longitudinals.
the point I was trying to make was rhomboids. So
That's what I put.
I wouldn't be that picky of a point, measuring things in millimeters on the real questions. So, and as she said, the questions, all of the questions, we have data on the question. You generate data on the questions, depending on the p-value and the r-value, which are different statistical means. That tells us it's a good question, a bad question, or if it discriminated between, if you scored in the top 20th percentile in your class, and those people didn't get the question correct, then it did not discriminate between the high performers and the low performers. It basically said people guessed. So, we generate those kinds of data on the test questions, and they can either get credit for multiple answers or tossed out. So, all right, so I forgot to talk about the other day, the thyroid. On Friday, I did dissect out a thyroid. I believe it was on the same, oh crap. I believe it was on the same body that I did the spinal cord on. That would be, what number is that? 3?
Yeah.
So 3 has a pretty good thyroid. Number 4 has an embryological remnant that you definitely need to take a look at on number 4. So the thyroid is an endocrine gland that sits just below the cricoid cartilage. It has a right lobe, a left lobe, and a connecting isthmus. The thyroid gland developed from the tongue, from the back of the tongue. And the tongue epithelium, when you were a little embryo, started to evaginate. And it formed a little pouch. That pouch descended down into your neck and then divided into a right and a left. And then the glands developed from that. So your thyroid, embryologically, again, arose from the back of your tongue. There is a little pit in the back of your tongue that you'll see later on in the week where it began from. That's called the foramen cecum. You can't see a foramen cecum in you because it's too far back there. However, as the thyroid gland descended, there in about half the population, there'll be remnants of that thyroid tissue or that duct that protrude upwards from the isthmus because it's coming down and then it splits into a right-left lobe. That is called the pyramidal lobe. And so about half the cadavers will have a pyramidal lobe. In that fourth cadaver, they actually have a duct that still persists between the pyramidal lobe and it probably goes all the way up to the base of the tongue. It's flattened, but it's still there. Okay? And you can see it. Some people, that duct, it's called a thyroglossal duct. It goes from the tongue down to the pyramidal lobe. In some people, that thing will develop cyst of fluid in it. So like you have a branchial arch cyst, you can have a thyroglossal duct cyst. So you can have thyroid tissue anywhere from the base of your tongue down to your thyroid gland. And in those people with a persistent cyst, it's a midline bump versus a branchial arch cyst that's a lateral bump. Okay, branchial arch cyst. Again, the thyroid gland is supplied by several vessels. All endocrine structures have a very robust arterial blood supply and a venous drainage, especially a venous drainage. You've got to get the blood into the circulation. Remember that the thyroid gland is provided by, the arterial supply comes from the superior thyroids, which are branches of the external carotid, and the inferior thyroids, which are branches of the thyrocervical trunk, off the subclavian. Okey-dokey. And there are other branches, but we won't worry about them. Okay, now, the purpose of the thyroid is to secrete thyroid hormone that regulates to a large extent your metabolism. Too much, you're skinny and jittery. Too little, you're sluggish and obese. That's a very, very, very broad statement, but it's pretty close. On the back side of the thyroid, there are 4 little glands illustrated in these by these little dots here. They're called parathyroid glands. These little glands did not develop like the thyroid. They didn't come from your tongue. They actually came from the branchial arches. They secrete parathyroid hormone, which causes calcium, your serum calcium, to go up. Pair up. That's how I always remember that. Pair up. Parathyroids cause serum calcium to go up.
Where did they come from again?
Just say branchial arches. Branchial arch, because they come from a singular branchial arch. Do you want to know exactly where they came from? If you're ever on Jeopardy?
Yeah.
Yes.
They come from the 4th branchial arch, a little structure called the ultimobranchial body. Who in the world came up with that name? Ultimobranchial body. They gave rise to the parathyroids that migrated behind the thyroid. Interesting thing about those things is you won't find them in a lab. They're too small. They just look like a little piece of a globule of fat. You won't be able to, you probably will not be able to identify them unless there's an adenoma of a parathyroid on your cadaver. However, it's important that you retain those parathyroids in thyroidectomy. That's one of the big things in thyroidectomy is you inadvertently remove all the parathyroid glands. In that case, it can mess up, to a certain extent, calcium levels in your blood. The friend of mine I told you about last week who had his thyroid taken out, didn't I tell you about his thyroid taken out? What the surgeon did was he took the tissue on the backside of his thyroid, kind of raked it off into a petri dish, chopped it up into little pieces, and implanted all of it into his forearm in hopes that the parathyroids would take root and survive in the subcutaneous tissue of his forearm. Is that not cool or what?
Did it work?
Yeah. So far he's measuring PTH in his parathyroid hormone in his circulation. So far they're still alive.
Thanks.
That's cool.
I mean, they do all sorts of weird things like that. If you have a craniotomy, they take off part of your skull, you know, to do something there. They'll take the bone and they stick it in your peritoneal cavity. And it stays alive in there for months until they need it to, until this is healed up and they can re-implant it. They pull it out of there and stick it back in there. There was a urologist friend of mine who said when he was a resident over at OUHSC, there was a guy that the voices were telling him to get after his scrotum with a potato peeler. You know, like a carrot peeler type thing. So he went and cut all of his junk up with a potato peeler, and so what they did in order to save his testicles, they implanted them into his thighs. And they stayed in there until the skin grafts and stuff healed up, and then they re-implanted them back into his new scrotum. That's kind of cool. So, anyway, that's not really related to this. But anyway, parathyroid hormones. There is a hormone that decreases serum calcium. That hormone is secreted by the thyroid gland. The thyroid gland. There's another subset of cells in the thyroid gland called C cells that secrete calcitonin that decrease serum calcium. All right. One of the other things about the thyroid gland and removing it is that right behind the thyroid gland, there are a couple of very important nerves. Here, we saw the vagus nerve in the neck last week, right here, the vagus nerve in the carotid sheath. It goes all the way down into the chest and goes even on into the abdomen. We'll see it down there as well. But when it gets into the chest, it sends off a branch. This little one right here goes up under the arch of the aorta. The one on the right side goes under the right subclavian. These nerves recur back up. These are called the recurrent laryngeal nerves. They provide the motor supply to the larynx. They are right behind the lobes of the thyroid. On this illustration here somewhere, I've got recurrent laryngeal nerve identified.
So are they just a branch of the vagus nerve?
It's a branch of the vagus nerve. Innervates the larynx, the motor supply to the larynx, your ability to talk. Open and close the vocal folds. On that third body, I think it's the third body, I have the recurrent laryngeal nerve identified. It's a pretty large nerve, and it's behind the lobes of the thyroid. So which nerve can be injured following thyroidectomy? Recurrent laryngeal. If you ding that nerve, you lose the ability to speak. Okay? Any questions about the thyroid? All right, so let's get out of the thyroid and go to the face. Before we get to the face, we need to do a little osteology here. We need to know the bones, the pieces and parts to the skull. The skull has two general parts. It's got the neurocranium, which houses the brain, and then it's got the viscerocranium, which is all the stuff in the front where your face is located. I've labeled all the pieces and parts to the, well, I did, this person did, all the pieces and parts to the brain here. You need to know what they are. There are 3 or 4 skulls in that box, in one of the bone boxes there. You need to pull it out, sit down with this illustration, and identify these pieces and parts. Okay? I won't go over them here, except to tell you identify a couple of things for you. Clarify, in other words, the difference between the nasion and the glabella. The nasion, you have the 2 nasal bones. You feel your nasal bones here, and you can feel the end of the nasal bones. It's pretty prominent, the end of the nasal bone. So the nasion is just this little dent here. The glabella is this ridge that's on top of the nasion. There's the nasion, there's the glabella. For you people that are more closely linked to Neanderthals, you probably have a pretty prominent glabella. Okay? Those of us who have evolved slightly more, it's slightly more depressed. In other words, if you went to OSU, you would have a big, thick glabella. Okay? Any questions about that? No, I love OSU. That's a nice campus. It really is a nice campus. There are a couple of foramina that are very prominent in the front part of the skull that you should appreciate. There's an infraorbital foramen up here. It's right here at the top of the orbit. And some people can actually feel it. If your face is thin, you can feel a little pit up there. There's an infraorbital foramen right here that's in the maxillary bone. And then there's a mental foramen that's down here in your mandible. And some people with a thin face can feel that mental foramen as well. Just because you can't feel it doesn't mean you have a fat face. Right? Suture lines, you need to understand the suturing between the frontal bones, the two parietal bones, and the occipital bones. In other words, you have a midline sagittal suture here connecting the two parietal bones. Between the parietals and the occipital is that point back here called lambda. And in front, between the frontal bone and the parietal bones, is bregma. Bregma in the front, lambda in back. B comes before L. Bregma is the soft spot in the little baby's head that doesn't completely fuse until they get to be about 1 year of age. There are quite a few other pieces and parts. I want you to know those pieces and parts. Any questions out there that might cause you some concern? If we look at the lateral part here, what I want you to appreciate on the lateral part is there is a sharp little spine that comes down from the base of the skull. It's called the styloid process. One of those skulls has a styloid process, the one with the tag on it. You can see the styloid process. That gives rise to a lot of ligaments and muscles that are going to go to the oral cavity and down to the hyoid bone. You'll see it. You can't feel it in yourself, and you can't feel it on a cadaver, but understand that it's there. Between that styloid process and the mastoid process, there's a little hole back over here, not the auditory, external auditory meatus, that's where your ear canal is, but up underneath the skull, between the styloid process and the mastoid process, there's a stylomastoid foramen. I'll talk about it later on in the...
Where is that hole again?
If you turn the skull upside down, the two styloid processes come out of the base of the skull, like that. So between the styloid process and the mastoid process, which is this big thick one right here, there's a little hole called the stylomastoid foramen. You'll see it in the lab. That transmits a very important nerve we'll talk about towards the end. Okay? The temporal bone here has several different parts. It's got a zygomatic portion here that will have a suture line with the zygomatic bone. The zygomatic bone is the one that forms the inferior lateral part of your orbit and starts your cheekbone. Now, interestingly about the cheekbone is there's a space behind it there. You really can't feel that space. You can feel the inferior part of the zygoma, but you really can't feel the cavity of the zygoma. You will be able to see it on the cadavers quite easily. Of course, the temporal bone is the zygomatic process of the temporal bone is where the mandible will articulate. I'll go into that more in just a second. Any questions? One other thing I want you to see on this illustration here is this peak bone here, or rose-colored, however you view that. This is a bone called the sphenoid bone. The sphenoid bone actually forms sort of the center of the skull. The skull is sort of built around it, if you will. It has several pieces and parts. In this illustration up here, on the top left, what they've done here is they pulled the sphenoid bone out. We won't be able to do that. You can't do that because it's the center of the skull. Nonetheless, the sphenoid bone itself has a central ridge and then two wings. Greater wings and they're large flat parts. And then lesser wings, which are thin little ridges. So it's got a big central part, two greater wings, two lesser wings. The central part houses the pituitary gland in a structure called the sella turcica. Somewhere in there is the sella turcica. It's a little cavity, that's where the pituitary gland will sit. Pituitary gland. So the pituitary gland sits up here, and then the sphenoid bone, that's the pituitary gland, the sphenoid bone comes down like this on either side. As it comes down, you'll find little holes in the sphenoid bone. One of those little holes is foramen rotundum. It transmits a nerve we'll talk about later. There's a little hole. And then there's a foramen ovale and a foramen spinosum. The rotundum and ovale transmit nerves. Spinosum transmits an artery. Those three structures are in the greater wing of the sphenoid. So here's the sella turcica, the greater wings come down off the sides, and then the lesser wings come off the top. So they're up here at the top. And you can see this is the greater wing, the lesser wing is up here. Now these two wings don't fuse. There's a gap between them. That gap is called the superior orbital fissure. And you see it right there. There's the gap between the two wings. The lesser wing and the greater wing. There's the lesser wing, there's the greater wing, there's the gap. I'll go into this structure more tomorrow morning, but I want you to see it here today because you want to kind of get a jump on learning the pieces and parts of the skull. All right. So if you're not dissecting today, I would recommend that you grab one of those skulls and sit down as a little group and start going through the pieces and parts. The scalp, before we get to the face, we've got to go through the scalp. The scalp is interesting, contains 5 layers. 5 layers. So you've got the skin. The skin would, of course, be the epidermis and the dermis right here. Underneath the skin, you have the subcutaneous tissue. This is dense subcutaneous tissue. So the skin, and then the subcutaneous tissue, containing lots of blood vessels and nerves. And then you have what's called the aponeurosis. The aponeurosis is actually a fascial plane that, if here's your skull on sagittal section here. Here's the back, there's the front. You've got this occipitalis muscle right there that moves the scalp of your occiput. You've got your frontalis muscle up here. You see the frontalis muscle right there? That's the one that raises your eyebrows. But those muscles are connected by that aponeurosis that runs this way. So here's the thing, when you're spending all weekend studying with your head down like that, and you've got stretch on that occipital muscle, what that aponeurosis does is it transmits that pressure to your frontalis muscle, and what do you wind up with? A frontal headache from
Makes sense.
having your head down all weekend, right? Okay? So they're connected across the top of your head. And it's a dense fascia. You'll see it in lab. Underneath that is the loose connective tissue layer, also called the areolar layer. Loose connective tissue. This is called the dangerous area because infection in that, because the connective tissues are so loose, and that's what allows your skull to move on your head. That's the loose layer that's moving. If you were to run, if you had like this thing was lower, and you ran into it like that, you could actually peel your scalp back through that loose layer. If you're going to scalp somebody, it's the loose layer that separates. That makes sense, doesn't it? Okay. Also, if you get a knock on the head, and you get a big golf ball here, you ever seen anybody with a big old golf ball like that? That's bleeding into the loose layer because it has flexibility. There's a, I guess it's a fetish, I'm not exactly sure what it is. I saw it on TV one night. It was the oddest thing. These people, it was over in Asia somewhere, like Japan, you know what I'm talking about? They take like a 26 gauge needle connected to an IV, and have you seen it?
I've seen that.
They insert it right here into the loop, underneath the frontalis muscle, in the loose layer. And then they let gravity take over, and they pump, the fluid drains into that layer. So you've got this big bulge here, and then what they do is they put their thumb in the middle of that thing, like that, and put pressure on it, and what you wind up with is a donut. So when you're on the pot this weekend, lymphogranuloma, inguinal, aphthostomatitis,
Yogurt.
Taylor's yogurt, and do a Google images for donut
Yogurt
head.
girl.
Do a Google images for donut head. That's what you're doing. It's in that loose areolar layer. Okay? Deep to that is the periosteum, the outermost covering of the bone. Wonderful thing about that is the easy way to remember those 5 layers is SCALP, spell scalp. Skin, skin, cutaneous layer, aponeurosis, loose cutaneous layer, periosteum, spell scalp. Yes, ma'am.
So if someone was scalped intentionally or otherwise, would it be the loose connective tissue separating from the periosteum or the aponeurosis in the loose connective tissue?
It rips in that plane. So as you peeled it back, on this side you would have the aponeurosis, on this side you'd have the periosteum.
Is the pericranium like the same thing?
Yeah, same thing as the periosteum. So you can also tell, it says right here, understand what would happen with a coronal versus a sagittal laceration. If you had a coronal laceration and it went through the aponeurosis, what would happen with the wound margins? They would gape, yeah, because you've got this directional force. If you went through the aponeurosis, you'd have a big old gaping wound like you see up there. If it did not go through the aponeurosis, you guys have a simple laceration. It bleeds like crazy because of the number of blood vessels, but it doesn't gape. That tells you whether or not you got through the aponeurosis layer. Now, if you have a sagittal incision, it will never gape. Okay? Makes sense, huh? Muscles of facial expression. You have 822,000 muscles of facial expression. And no, you don't. You only have these right here, plus one more. And I don't want you to spend a great deal of time trying to dissect out, is this the zygomaticus major or the zygomaticus minor? Is this the levator superiori, labialis? You know, I want you to just remove the skin, and you have to do it sort of superficially, like you did the platysma. I'm sorry about I spit on you. Like you did the platysma, because these muscles attach to the skin just like the platysma did. That's why you can move your facial expression muscles. That's why you can move your face. What cranial nerve? What cranial nerve?
Facial.
Facial. Okay, facial nerve. A couple of them that are sort of interesting. My favorite, well, one of my favorites is Procerus. That's the one that you do this with. The other one is Rhizorius, which is the one you do that with. You have 2 levators for your upper lip. You've got one for the lip itself, and then you got one for the angle that goes up. You got 2 depressors, one in the middle and 2 off to the side. You got the mentalis or mental muscles. Those are the ones people, they contract. You can see the little dimpling on their chin like that. Zygomaticus
Turn around and show
major,
us.
and minor help smile. There's one that's not, yeah, here it is, right there, buccinator. It's kind of deep into the substance of your cheek there. That's the one, when you puff out your cheek, that's your buccinator.
What is
Okay.
Procerus again?
Huh?
Procerus?
Procerus is this one right here.
That's the one with Botox.
What do you do? I wanna see the expression. Okay, cool.
The one that's the most ridiculous one is this one right here. Levator labii superioris alveoli nasi. That's the one, people, I can't move my nose, but people can flare their nostrils. That would be over here, the, where is that? Compressor nares, you know, they can move their nose all over the place. So, again, I think the issue here is that, you know, you should be able to easily dissect the frontalis, but if you pull that off of there and you're looking at bone, you've gone too far, right? This area right here overlying the buccinator is filled with fat. I want you to remove that fat so you can see the buccinator. That's important for you to be able to see. The clinical test for these things, this is the seventh cranial nerve, and I'll show you how they get innervated in just a second. But when you're doing a physical exam on somebody and you're testing cranial nerves, to test cranial nerve 7, what I'm going to get you to do is raise your eyebrows, okay, smile, frown, puff out your cheeks, okay. I just tested cranial nerve 7 by getting her to do these facial expressions. If she has a stroke or Bell's palsy, she's not going to be able to do these, what's the name of the professor upstairs?
Oh, Dr. E.
Engelbretson?
Yeah.
Engelbretson?
Yeah.
I don't know, I haven't paid attention to him, but I think he's had Bell's palsy.
Yeah.
If you see him, what does he teach, chemistry or biology?
Chemistry.
You'll see him coming down the hall, he's a big guy, but half his face is droopy. And he's got a, I don't know how long ago he developed this, but I think it's probably permanent in his case. About 5% of Bell's palsy never heals. And if you see him upstairs or see him walking around, you'll immediately know if you could test his cranial nerve function, 7 function, there would be a deficit there.
That's like my worst nightmare, get Bell's palsy.
That's your worst nightmare?
One of them.
Oh, no, I go back to Taylor's.
Does the visual nerve do motor and sensory innervation or just motor innervation?
We'll cover that, but it's just motor to the muscles of facial expression.
How do you tell between
Just
Bell's
motor.
palsy and a stroke? Isn't there like a sign showing one or the other?
Yeah, it's not well, it's not an easy thing to explain, but let me just, I'll give you the final word. If you have, so it's innervated by the 7th, all of these muscles are innervated by the 7th nerve.
Figured out. So you said the buccinator is fatty, or is it the area outside it that is fatty?
No, the area overlying the buccinator is fat. There's a thing here called the buccal fat pad. Even in thin people, it's pretty fatty. Okay, so the real quick test for Bell's palsy, if you have Bell's palsy, you cannot work any of the muscles on that side of the face. None of them. So that means you can't raise your eyebrows, or the eyebrow on that side won't raise. You can't smile, you can't frown, you can't puff out that cheek. If you have a stroke, you can still run your frontalis muscle. You are paralyzed for the rest of them, but you can't run the frontalis. So all you got to do, if you're trying to distinguish between a stroke and Bell's palsy, say raise your eyebrows. If you can raise your eyebrows, you're having a stroke. If you can't raise your eyebrows, then you're most likely having Bell's palsy. If you look on the Engelbretson,
I'm gonna ask him if he can raise the eyebrows.
yeah, if you have a good relationship, I'm going to pick on you. Just fix the front. So you see where he's got these. You see where he's got these lines right here? Natural lines in his forehead. A person with Bell's palsy, if you look at Engelbretson, do that again. Kind of raise your eyebrows, raise your eyebrows. This side will be smooth. And it will be smooth to the midpoint. Right? So if he's walking down the hall and you look at him, one side he will have no ridges in his forehead. So that's what they do with Botox, you know, they just go and paralyze the nerve, the neuromuscular junction, and you wind up losing the ridges. It's kind of interesting, now you look on TV, at all the actors and actresses, how many of them have no furrows here, they have no lines in their forehead, you know, you can tell from all the Botox.
How do some of them have it and some of them don't, Jen?
I'm sorry?
How do some people have the lines and some don't?
The more lines you have is an indication of the more intelligence you have. So I had to walk all the way up there. He and I, we got a bunch of, all you people along the side here, dumb as stumps. No, I don't know. I mean, I don't know. I just made that up. Yeah, actually, there is a little bit of a thing. The more tighter and moisturized your skin is, the less likely you are to have these lines that we've worked so many years to get. So, a couple of other muscles you need to appreciate, because I was going to do her, but I mean, she had like nothing.
Let's
So,
see it.
you got Botox? You been doing Botox?
Right, we can tell by your lips.
Two other muscles that are important here. One is the orbicularis oculi and the orbicularis oris. These are circular muscles that go around your eye and your mouth, respectively. The orbicularis oculi helps close your eye, well, closes your eye, doesn't help, it closes your eye. Orbicularis oris closes your mouth, you know, like pucker. Okay?
So, two questions. One, so does the orbicularis oculi, it's inside of your eyelid as well?
Yeah, when you dissect the skin away here, you will find muscle fibers running. Now, remember these muscles are like platysma. They're slightly more thicker. When you get into the oris and the zygomaticus, they're thicker. But when you get up in here, you got to be a little careful. The frontalis is also thin. I mean, you can feel how you feel like the bone is right there. Well, there's a muscle between your skin and your bone. Okay, so it's a very thin muscle. And of course, we had platysma, and I've changed the order of these slides here. That's why it's not the same on your presentation. Platysma is a muscle of facial expression. You guys saw that the other day. It too is innervated by cranial nerve 7. Muscles of mastication. There are 4 muscles of mastication. These are different than the muscles of facial expression. The 2 muscles that are most readily apparent are the temporalis muscles and the masseter muscles. The temporalis muscle, when you open and shut your mouth, you can feel the temporalis muscle right there above the zygomatic arch. Very obvious. The masseter muscle, when you bite down right here, you can feel the bulky masseter muscle right here. All right, so one of the things about testing cranial nerve 5 is you just take the person, kind of turn that way a little bit, so you just put your hands right here, bite down, and you feel how tense these muscles are to make sure that they're contracting equally on both sides. Okay? There are 2 other muscles of mastication, and those are the medial and lateral pterygoids. I'll show them to you in a minute. What cranial nerve innervates the muscles of mastication? Anybody know?
Trigeminal.
Trigeminal nerve. Trigeminal nerve. Trigeminal nerve does muscles of mastication, all of them. Facial nerve does muscles of facial expression, all of them. You can see where they arise here. The temporalis muscle arises in the temporal fossa on the skull up here, this depressed area, and inserts on, you'll see it in just a minute, on a part of the mandible called the coronoid process. It's underneath the masseter. You'll see it in the next slide. The masseter arises from the zygomatic arch and comes down and inserts into the angle of the jaw here, the mandible. It's on the outside. Before we get into more muscles of mastication, let's talk about the nasal cartilages. We know about the 2 nasal bones up there. The nasal cartilages, dense connective tissue is what these are. They're pretty tough little structures. You can feel the septal cartilage that forms the entire septum inside your nose, except when you get down towards the bottom, it becomes bony. But the top part of the nasal septum is all cartilage. You have the alar portion and you have the lateral portion up here in the top. Okay, is that all right? Fibrofatty tissue is what forms the flared out portion here. This is not cartilage, this part out here. And then, of course, you got this is a nares or a nostril containing boogers. I'm not sure if boogers has one G or two. I debated on that for quite some time and settled on one.
So do we have,
Ordinarily, your finger is right there, but anyway, go ahead.
do we have
The
one?
most
hour?
common cause of epistaxis, which is a nosebleed, is digital manipulation. In case you're on Jeopardy, I'm not kidding you. Digital manipulation is the most common cause of epistaxis. And a lot common cause of a lot of other things, but in terms of nose, it's epistaxis.
Dirty.
That gets back to Taylor. Go ahead.
Do we just have one septal nasal cartilage?
You have one septal nasal cartilage. It's the ridge you feel right here that if you stick your finger on the inside, you can feel, go ahead and put your finger in your nose. Don't tell me you don't put your finger in your nose. Is that part right there, okay? Oh, that's probably on camera too.
Whoops.
When we do the nose next week, the inside of the nose, I'll show you where the vasculature is. It's so thin, that's where you get the nosebleed so frequently.
One more time for the camera.
No, one more time for the camera, no. All right. Here's an example of when your nasal bone gets fractured, not the cartilage, the nasal bone is shifted here. And of course, you can reduce those in the emergency room, or you can just wait, usually because of all the swelling that usually goes along with this, you wait another day or so and then adjust it then. But you can see the fracture line going through the nasal bone itself. Again, cartilage does not show up on an x-ray. So you're not going to see, I mean, you can sort of see the cartilage, but not really. That's the bone. Okay? All right, now, somebody was asking, or you asked earlier about the masseter, muscles of mastication, sensation. The fifth cranial nerve gets sensation to the face, all of the face, from up here in the forehead to the maxilla down to the mandible. The fifth cranial nerve comes off of the brain stem here at the level of the pons. That's the pons. If you're interested in brain stem, the highest brain stem component is called the mesencephalon, and then the pons, and then the medulla. The fifth cranial nerve exits the pons. We'll see it when we take the brain out tomorrow. All right, so it travels a short distance there. There would be the pons. And then there's a huge swelling right there, about the size of a quarter. It's large. It sits on either side of the sella turcica. That is a ganglion. It's called the trigeminal ganglion. You might also hear it referred to as the Gasserian ganglion, the semilunar ganglion. It goes by a bunch of different names. That contains all the cell bodies, the pseudo-unipolar pericardia of the somatic afferents from the face. Not only just the skin of the face, but inside the oral cavity. When you touch the buccal region, your cheek, that's the fifth nerve. When you touch your cornea, that's the fifth nerve. And it's divided into three divisions. The ophthalmic division, you see, gets like from the angle of your eye up, but it goes down to the tip of your nose. Then you've got the maxillary division and the mandibular division. That's how the trigeminal nerve is arranged. Did that answer your question? Have you ever had that question? Okay. Yes, ma'am.
Where do the synapses of these take place?
Where does the synapse take place? what would be the analogous structure from the mandible down to the trigeminal ganglion?
Dorsal root ganglion.
A dorsal root ganglion. Is there a synapse in a dorsal root ganglion?
No.
There's no synapse in the trigeminal ganglion either. You have receptors in your face. The synapse is going to occur in the brainstem. The synapse is going to occur in the brainstem. So
The cell bodies are in the trigeminal ganglia?
Uh-huh.
Okay.
yeah. So now you know of two sensory ganglia: the dorsal root ganglia and the semilunar. Alrighty. The question here is, somatic apical pericardia for the face are in the trigeminal ganglion. That's what that picture shows. Where would you find the pericardia from the posterior scalp? Where are these?
Dorsal root ganglia.
Dorsal root ganglia. Which one? C2. There. So you can abbreviate this cranial nerve 5 as Roman numeral. So V1, V2, V3, C2, C3, C4, T4, T10. There you go. So you kind of learn these things. That makes sense.
What leads to trigeminal neuralgia?
Trigeminal neuralgia is an inflammatory process involving this nerve. And all sensations are transmitted over this nerve. Touch, pressure, proprioception. Proprioception. What proprioceptors would you have with this? What is proprioception of the face? I mean, it's not like you have limbs in your face. Yes. Can you tell me right now, is your jaw open or shut? You have proprioceptors in your TMJ. That's fifth cranial nerve. Pain is also associated. So it's an inflammatory process. Usually it's brought on by a viral infection that leads to abnormal discharge, and they have this horrendous pain coming from the face. Okay. Any other questions about this? Excellent. Yes, ma'am.
Can you go over the sensory from C1 to C? I'm sorry. I didn't see.
Yeah. V1. So these are, you see where that's designated V3? So V1, V2, V3, C2, C3, C4. We know C4 is the supraclaviculars because the liver, the diaphragm abscess produces shoulder pain, so it's C4. And I said the nipple line was T5, and then the umbilicus was T10, T4, T4. I said it was T4. Mine are a little lower. Which is exactly why you smiled when I did that the first time. Mine are a little lower. Mine are T5. Some of y'all wait till you get my age, and it's going to be like T12. This is T10. Well, that's, if this is C3, then C4 is down in here. Remember the transverse cervical nerve, that part? Yeah, it's cervical plexus. You know, and like I say, if you just know that it's cervical plexus, you're in the ballpark. Okay? All right, this is an example of herpes zoster. Herpes zoster is a reactivation of the herpes virus, or the varicella virus, or the chickenpox virus you may have had as a kid. You guys may not have had chickenpox because you were immunized. People my age, anybody in here had chickenpox? Oh gosh, most of you did. Well, you were before the vaccine. I guess y'all were before the vaccine. Well, so that's good and that's bad because if you had it, you won't. That means that the virus, the DNA of the virus, is still in you. And it's in the trigeminal ganglion, the afferent pericardia of the trigeminal ganglion. It can reactivate at times. The older you are, the more likely it is to reactivate. And what you wind up with is a very painful, blistering rash along the dermatome. It can occur at any dermatome, somatic or trigeminal distributed. This is a V1, or herpes zoster ophthalmicus. The problem with this is, because I said the cornea is also innervated by the fifth cranial nerve, that's V1, you can wind up with what are called dendritic ulcerations of the cornea. You can actually lose your eyesight. So anybody have herpes zoster of the V1 needs to be followed by an ophthalmologist. You don't need to be messing with that. Anybody coming in with a blistering or tingling at the tip of the nose, like I'm getting a cold sore on the tip of my nose, even though no rash has manifested itself yet, we need to get them on antivirals just because. Okay, the older they are, the more likely is that you should do that.
So if the DNA is in your trigeminal ganglia, and if you get this chicken pox.
I may have said that, I don't remember if herpes is a DNA or RNA virus. Anybody know what off the top of your head? The genetic code for the virus is still in your, it's just silent.
Yeah.
If it's genetic, why do they say it would pass to somebody else? It would be communicable. Would this be communicable?
If the cells of the trigeminal ganglion have the genetic material in them, when you transmit that's an autosome. You don't transmit that when you have babies. You see what I mean? I guess if you had herpes of your sperm or of your eggs, you could do that, but you don't transmit that. You see what I mean? You don't transmit this. That's localized. Now, since this contains active virus, you should not be around, if you've never been immunized or never had it, you should not be around anybody with an active lesion because they're shedding virus. Just like if you had a cold sore. Cold sore is herpes, right? Herpes simplex. You can transmit that by just touching. That's how it's transmitted. Or herpes simplex down here.
So since the majority of us have had chicken pox, if we're treating someone with shingles, that doesn't increase our likelihood of getting shingles?
No,
because we already
it's
have that
yours,
virus.
not theirs.
Okay.
How do you get cold sores? Because like my mom would get them and I get them and my brother does, but my dad doesn't and one of my other brothers doesn't. So how do you get them?
They just were never exposed. Now, so you never kissed your mom when she had an active cold sore.
Mm-hmm. Okay.
Your mother, when you were a little baby, and she had a cold sore and she didn't realize it, she might have, oh, little girl, kissy, kissy. She could transmit it to you, and you didn't, your aunt or somebody, you didn't, you just got it.
Should have been like your brother.
Yeah, and then some people who have herpes, they will get cold sores at the drop of a hat. Any trigger will give them a cold sore. Every exam they have in PA school, they get a cold sore. You look around, you'll find out who those people are here next week. But other people with herpes, they might have a primary outbreak and then never even have another one. So it's very individual.
So I know cold sores and fever blisters are related.
The same thing.
It's the same thing, but one's induced by heat?
Heat? No. I don't know why they call them fever blisters.
Because I never got cold sores ever, and then my lips got super, super burnt one summer, and ever since then I've had cold sores.
You have herpes.
Well, I know that.
No, it's the same way with me. It's the same way with me. I don't know if you guys know this, but let's see, when was it? Was it you guys? Maybe not. If I get sunburned, I will, break out with herpes, and I take acyclovir or Valtrex. I mean, I take it like Skittles. And it's just, it's not heat, it's sun exposure is my trigger. For some people, it's the time of the month. Some people, it's stress. Some people, it's chocolate. So it just varies person to person.
Fever can be a trigger too, and I think that's where it...
No, not fever. Decreased, immunocompromised because of an illness that has produced fever.
Gotcha.
It's the immunocompromised nature of having an upper respiratory infection, something like that. It's not fever itself. And that may be how it got its name, I don't know. They always popped up people who had a cold, had fever, and they wound up with a, yeah.
So herpes zoster then can be found in the trigeminal ganglia, and where was the other place, the spinal nerves, or?
It can be found in the dorsal root ganglia, and it's very, it's, when it manifests, it's unilateral, it's always unilateral, and it's always blistering, and it's always very, very painful when it happens.
I got it 3 years ago.
You got what?
I got shingles.
Shingles is the other name for it, shingles. What dermatome are you?
It would be probably around T7.
T7, yeah. When did you get it?
I was either 19 or 20.
Yeah.
So
They say if you live long enough, you'll get shingles. Now, there is a vaccine that they're recommended people over the age of, is it 55 or 60? 60, I think, yeah. They take this vaccine to prevent shingles.
So I didn't get chickenpox, but would I be more susceptible to get shingles?
Were you vaccinated as a kid? The problem with the vaccination is no one knows how long it lasts. So I can tell you right now that chickenpox in an adult is a very horrendous rash. I've seen one person with chickenpox as an adult, and I mean they had a little pox sting every square centimeter of their body, and it was horrendously painful. So I don't know why they even came up with the chickenpox vaccine in the first place. All right. I mean, there is some scarring that can occur with people with chickenpox. There's a few days off of work that one parent has to miss, but really it's pretty a benign disease for the vast majority of people. I don't know why they pixelated this eyeball and didn't do that one. It seems rather stupid to me.
Maybe that one was kind of open or something, so they felt like they had to hide their.
It must have been, yeah. So, all right, so we talked about V1, V2, V3. They come out the 3 holes that basically they come out the 3 holes we talked about. Supraorbital foramen transmits the supraorbital nerve, which is V1. The infraorbital nerve transmits V2, the infraorbital nerve. And the mental foramen transmits the mental nerve, which is V3. So that's how you get the sensation or the nerve supply to the face. It's pretty easy to find all 3 of those nerves. Okay, you should be able to find those on a cadaver. There are a whole bunch of other nerves, like the supraorbital, supratrochlear, infratrochlear, zygomaticofacial, zygomaticotemporal, all those things. I don't really care that you know those. Just those 3 are the big ones. Supraorbital, infraorbital, mental, V1, 2, 3. Okay, take a break. We'll come back at 2 o'clock.